Today we're going to talk about bladder stones. This comes as a short note and sometimes as a Viber table question. Radiology maybe as a specimen or I mean normal Viber. Okay, but the problem is most of our students who are not working in a busy urology centers don't have much knowledge about those clinical nitty-gritties. Clinical nitty-gritties that are common with bladder stone because normally if a person is not working in a urology training institute, he's not much exposed to his bladder stones. Only few theoretical topics which we normally, even after so many years after being passing our exit examination, we normally tend to forget or tend to overlook. Okay, so with this in mind, let me start today's presentation on urinary bladder stones. Okay, let me open. Okay, fine. So as you can understand, is the bladder stones look like a jackstones. Normally, we knew it from our old school. I mean, I mean, we are taught biology lessons in our school. All mulberry stones, jackstones, all these gory stuffs. Okay. Now, as you can understand from the anatomical picture, this is a bladder. This is basically the two ureteric orifices, and between the inter-ureteric marcia ridge, and then we have this is known as a trigone. And at the end of the micturition, this stone comes and like put in a flip a coin in those wash basins and comes and settles down. Well, move and then settles down and cannot move out, and it irritates the trigone. So often you have strangulate, the pain at the end of mixture, tremendous excruciating pain. And it's known as strangulate. And even in a child, he will cry. Literally, a kid will cry and will pull his penis. That's one of the reasons. Pull his foreskin or the penis. It's one of the reasons. That's one of the signs who are known that the person or the patient or the kid is having a bladder stone. This is one of the pictures I've taken it, and it, as you can show, it's a huge stones. But don't ever believe only on a plain X-ray or a straight X-ray before you cut open his her belly. Always do an ultrasound or a CT scan or a cystoscope, because I had this problem in my residency days when I cut open somebody's bladder, thinking it to be a bladder stone, looking at this picture. And at the dead of the night, because normally we had this during our residency period when we were doing emergency duties, and we normally used to try to put some cold cases in our emergency. You can own our own skills. So at the time at 2 a.m. with acute retention as an emergency indication, we took the patient and opened his bladder just to see in dismay that the blood is actually empty. Then we did an ultrasound the next day around, and after dismay, we were found to be a calcified retroperitoneal tumor. Okay, and in that case, we actually did a DRE examination later the day, and we actually could palpate that mass lesion. So normally bladder stones are not palpable. If you palpate something with this form of body picture, it may not be bladder stone, it calcium. It's very common in elderly or middle-aged females who have a calcified dermoid cyst, very common of the ovary. Now, bladder stones are usually associated with urinary stasis, and urinary infection increase the risk of stone formation. Very important, primary bladder stones. Why are they called primary? Because it's not associated with obstruction, not associated with any functional abnormalities. They're mostly common in children, in known as endemic stones, in children in malnourished countries, children who depend only on breast milk, and the mothers are also malnourished. Okay, and these have less amount of phosphate in their diet, more amount of uric acid in the urine, more amount of ammonia in the urine, more amount, and all these patients have primary bladder stones. And once they have a single stone, less than 10-year kids, remove them and they're fine. And but you have to take care of the nourishment. That's very important. Any other form of stones, secondary stones. They can have due to obstruction. They can be stones that are generated in the kidneys, then come into the ureters and into the bladder, but they are mostly more than 17% as per recent evidence in Campbell's literature, Campbell's urology. Okay, they can't be more than 17%. Most of these stones which come from the kidney, pass to the ureter into the bladder, they pass off. Only the person has a difficult urethral stricture of a large median lobe, they get stuck and they can't move out. Okay. So that's very, but no recognized association with ureteral calculi. This is one blanket statement. And how does a bladder stone form? I said bladder stone form in PPH, originating from the kidney, and the stones which are additional stone material, mostly in sutures. Okay, stones forming over foreign bodies, right? Foreign bodies like a staple or a non-absorbable suture used to, suture the bladder. Somehow there has been some gauge pieces left behind after BVF surgery. A gauge piece stand, a gauge piece being left behind is a very rare occasion. A strand of the gauge piece being left behind. They can also cause a bladder. They're very common, and they are very hard stones. And all these blood and catheters being part of it, catheters being left behind, or the catheters being kept for a long time in trustation in stone formation. Infective cases, neurogenic bladders. Okay, patients who are quadriplegic, catheters for a long time. They also develop even DJ stents, double J stents being left over for more than required time. They can also form, and also this radiation therapy and schistosomiasis from bladder stones, bladder cancer is very common, and bladder augmentation surgeries and urethral strictures. Okay, so these are the arteriogenic foreign bodies, surgical gauze. This is basically the list of it. Children, we have talked about it. The most common is open surgery, but now we are using SPCL in children. So SPCL is just like putting a SPC catheter in acute retention patient. We put in a small bore, we put in an amplas sheet, just like in a PCNL, put in a nephroscope, break the stone. The importance of this is we are keeping the urethral instrumentation time to a minimum, because if you have a large stone, or if you have a stone in the bladder with a small kit, well, the urethra being smaller than the whatever size, you don't have a, because you are using ureteroscope only in those cases, and you can take a longer time to break the stone, and the urethra is basically damaged beyond recognition. Okay, the urethral mucosa gets damaged beyond recognition. That's very important. SPCL is now the treatment of choice, but again, open surgery again holds the key for these large bladder stones and stones in the kids. I see BPH and bladder stones are very common, and they're mostly associated with infections. So the infection stones are also very common. So ultimately, it's primary, secondary. The mixed stones are very common, calcium oxalate stones, and we have uric acid stones. Mostly they are found in children. There's children endemic stones, primary stones, and also patients with ileostomies after radical cystectomies. Patient on ileostomies, all these loops ileostomies, they form these uric acid stones. They are not very radiopaque. They're radiolucent. Remember, you have to do a CT scan to do this. A triple phosphate stone, infective urinary cystine stones are rare. Symptoms, the mostly sometimes some patients will actually are very asymptomatic. They rarely present with the IETD symptoms, and some come with low abdominal acute retention are very rare. Only patients, if you will see a patient in your clinical package, a young patient, he had a ureteric colic a few days back, now present with acute urinary retention. Remember, in a young male patient who has an acute urinary retention without any past history of urinary problem, and had a few symptom of loin pain which he neglected, is a sign non feature that the patient is having a bladder stone. Put in a catheter, the patient is relieved. Okay, then you do an ultrasound, it's in a bladder stone, then go for surgery. Right, these are the different topics, and they are more common in men. And the frequency, strangury, hematuria, interrupted white histamine, UTI are the clinical features. These are differential diagnosis. You have fungus ball clot, papillomastoid carcinoma, urinary tract infection, and BPH. Diagnosis, obviously, previously prehistoric era, we used to pass urethral sounds like things like this, the von Buren sounds, or the Clarton's dilators, or there was another name I just forgot, and they were known as urethral sounds because you have to pass the anecdotal surgeons used to pass it to the urethra and sounded and made a tinkling feeling of that tinkling sound which they have manipulated and had a tactile sensation. That's known as sounding the stone. And from there, they have this urethral dilators being called as urethral sounds. Now, today we already found a plain X-ray, bladder ultrasound, CT scan, and cystoscopy, their confirmation. So uric acid stones are radiolucent. They may have an opaque calcified layer, and patient may present in acute retention. This is the large stone, but again, you see from the picture, they have also a halo effect because this is a patient with chronic retention. And the bladder looks like this, even though this is a straight X-ray. There is no contrast being injected, remember. So this is a cystoscopy. Always need to because when you see this picture, say I want to confirm with doing ultrasound, CT, or a cystoscopy before I put my knife on his belly. This is the sounds that you have to evaluate the patient as with any bladder stones, and the medical treatment, mostly as theoretical aspects that people are doing those nephrostomies, putting in catheters, flushing it with alkalizing solutions, and whatever. So this is mostly theoretical stuff. So surgery, mostly the open surgery, but nowadays we have transurethral surgeries, we have transurethral urethroplex, assisted. Now the most important is holmium laser fragmentation. Okay, so even if a patient is having a HoLEP surgery with a large prostate and having a bladder stone, you can use the same sitting, you can go for the bladder. Holmium laser is very good for breakage of stones. Okay, or we use an SPCL as I talked about. Okay, and ESWL is very rare. Somebody use a Morna punch also. Yes, cystolythal epoxy phosphate also they're used. They're also good for the Viva tables, instrument tables. And but Morna punch are very liable to punch stone and punch the bladder mucus also. They may hemorrhage and they get bladder perforation. Now, this is the typical picture I said. This is the recess behind the enlarged median lobe, which is housing the bladder stone, because there's a three-dimensional space behind that that prostate median lobe, where the bladder stone actually lodge. This is the prostate with the prominent median lobe, bladder wall thickening, and this is basically a non-contrast CT scan. Okay, it's a non-contrast CT scan. And bladder stones, in case of bladder stones, when these are mainly basically in very elderly patients, very unfit, less than 2 centimeters, to flip the patient around. So the patient is in prone position under CM guidance, you put in the shocks and you break the stone. Put the patient is on catheter, first flush the catheter, see the stone, and then we also use the ultrasound if possible. Then suck out the water. The stone is being fixed, and then you blast the stone with hydraulic or pneumatic, or all the different types of lithotripses we have in our material. So the role of embryology we talked about. Basically, we have the transurethral, but transurethral can cause a lot of time, a lot of instrumentation time with a kit. Then the urethra is normally narrow. If it's an adult, again, any instrumentation more than 2 hours. If you have a very large stone, can cause urethral stricture. In those cases, you use SPCL. That's very easier done. UA diversion, that's the last slide we're going to talk about. UA diversion is patients after doing radical cystectomies, all those patients with the box continent pouches. Ureterosigmoid is a very more common because you have the poop and the pee mixed together, and you have all those biochemical problems going together. The patient will have this bladder stones. Okay, so also ileostomies, loop ileostomies after radical cystectomies. You have to do a luposcopy in those cases. Use a holmium laser with a flexible scope, and then just break the stones and flush them out. It's very difficult if you have a cox pouch or this new bladders with difficult continence mechanism. Even mitral is contraindicated. Then you have to open. That's a heck of a job, but still you can't do all this fancy stuff with laser if you have a mitral. It's a very important topic because nowadays we have patients surviving for a longer period of time after radical cystectomies in all those urinary reservoirs. So these are stones in urinary reservoirs, and so that's it. That's it for today. If you have any question, can you comment on the comment section or send me a mail, or you can look up into my website also find relevant topics of interest. Okay. So this is for all, and bye bye for now. And I will be coming again with another course material. Bye bye.